I'd like to welcome everyone to the 38th Annual Shelley Lectureship. Dr. William Shelley was the Director of Surgical Pathology at Hopkins from 1960 to 1970. He then went back to his hometown or home estate in North Carolina, where he was an academic pathologist there. And he was lecturing in Charleston, and he was taking, at that time, Eastern Airlines flight back to his hometown in Charlotte when there was a lot of fog, and actually the airplane crashed on landing. And Bill Shelley died several days later as a consequence of that accident. And after the accident, the family was very generous and set up 2 Shelley lectureships. One here at Hopkins, which you're participating today, and one in North Carolina. And by coincidence, this Saturday, I was actually the Shelley lectureship in North Carolina. And it was gratifying in that I was able to hear many of Bill Shelley's colleagues, I never knew Bill Shelley, but many of his colleagues speak about his broad expertise in surgical pathology. His expertise was in breast cancer, but for example, he published an article in JAMA on prostate cancer even. He was also extremely well loved by many just for his very warm personality. And so it's with great pleasure that I'm able to introduce our Shelley lectureship, Dr. Arie. Arie did his residency and his medical training at UT Southwest in Dallas. After his training, he went to do a surgical pathology fellowship and a neuropathology fellowship at the Mayo Clinic. He stayed there 1 year, and then he went to WashU in St. Louis, where he was on faculty. 4 years before now, he moved to UCSF, where he's currently the professor in pathology, neurosurgery, and he's the director of the neuropathology lab. Arie's been very prolific. He has over 230 original publications on numerous editorial boards, numerous book chapters. He's an editor along with Daniel Bratt, who used to be here at Hopkins, on Practical Surgical Neuropathology, a major textbook on neuropathology. And some of the most, I think, well-known articles that Arie's done that has impacted all of us who practice in surgical pathology. He's been instrumental in the grading of meningiomas, which we use today. Also, his was one of the first articles on the loss of 1p19q in oligodendragliomas. And a lot of his work, and some of which we'll hear today, is on a combination of both routine pathology, immunohistochemistry, molecular biology, and cytogenetics in the diagnosis of brain diseases. Finally, there's something very unique on Arie's CV. You start seeing that on the other category, there's listing of various invitations that he's been interviewed on, called the Singing Doctor, the Singing Brain Doctor. He's been even interviewed by NPR. And so I'll leave that as kind of a mysterious intrigue, and you'll hear a little bit more at the end of his lecture on that. Today, we're very fortunate for Arie to be lecturing us on Biomarkers Neuro-Oncology.
Thank you very much, Jonathan. It's really a great honor to be here. I was here about 10 years ago to give a pathology grand rounds, and it's really amazing how things have moved since that time. Basically the whole talk was on 1p and 19q, and the biomarkers field has just exploded since then. Just to give you a sense of this moving target, I just got an email this morning from one of our residents that there's 3 new biomarkers in pediatric gliomas, and we have to start working on them. So something I got to read on the plane on the way back. Anyway, so I'm going to talk about mainly gliomas and the biomarkers we're using, but a little bit about embryonal tumors and some of the other non-diffuse gliomas as well. So I have no relevant disclosures, just the average poor pathologist like the rest of the other pathologists. These are the objectives, which hopefully you maybe have a little chance to read in advance. We will not go through them in detail. Okay, so to start with, you all know that we mainly use the World Health Organization classification scheme and grading scheme, and mainly what I'm going to focus on are the gliomas from grade 2 to 4, all the diffuse gliomas. Okay. So more and more over time, I would say neuro-oncology has definitely become very multidisciplinary, and we're kind of all like the blind men feeling different parts of the elephant. And then I'm sure you have tumor boards here like we do. Once a week we all get together and share our piece of the elephant and try to come up with the best plan for patients. I would say with this analogy though, this individual right here is the pathologist, and that's because he is getting the most important clues. I would argue he actually knows this is an elephant. The problem is he doesn't know how aggressive this elephant is compared with other elephants. And he doesn't necessarily know how this elephant will react to various treatments. And that's kind of where we are with classification, morphologic classification of brain tumors as well. So there's a couple of things about the histology that help us. Prognostically, one is, even though it's very subjective, determining cell types. So oligodendrogliomas do better than astrocytomas, and mixed tumors fall somewhere in between. And then, of course, not terribly surprising, the grade also is very powerful prognosticator for patients with gliomas. And so you may say, well, why do we need any further? I would say really within each of these categories, there's still tremendous variability from one patient to the other. And this is why we hope to get some other clues besides just morphology. Now I would say, I've heard, especially over the last decade, pattern recognition has almost become a dirty word. It's something that clinicians like to tease us about. You know, you're still using that ancient thing called a microscope and doing pattern recognition. Of course, what they don't realize is that they also do pattern recognition every day, and everybody, you don't have to be a physician to do pattern recognition. So it's actually a very powerful tool. It's something I don't think we should throw away. But just to illustrate the point, really within a millisecond, your brain told you, factored in hundreds of characteristics and told you this is Elvis Presley. We didn't have to do image analysis, we didn't have to do immunohistochemistry, we didn't have to do molecular biology. This is Elvis Presley. But of course there are some imperfections with pattern recognition and some problems, right? So, for example, it's likely that the early stage Elvis Presley has a better prognosis than the late stage Elvis Presley. Right? And this is a little bit the same as what we do with brain tumors. It's kind of when in the stage of development do we catch them. Perhaps more importantly though, for those of you with a good eye, this person right here and this person right here are not Elvis Presley. They're Elvis Presley impersonators. And this is something we grapple with tumors as well. And sometimes two tumors that look remarkably similar have very different biologic behaviors. So we'll talk a little bit about that. So in neuropathology, we sometimes run into some other problems with this. So just to continue the analogy, I know the people that are too young won't recognize this is Colonel Tom Parker, who was Elvis Presley's manager. Was said to be extremely aggressive, whereas other managers demanded 10% of the cut, he took 50% of the cut. So let's just say we have this mixed Elvis Presley, Colonel Tom Parker tumor, but it's in an eloquent part of the brain. And the surgeon can only do a needle biopsy. Right? Depending where that needle goes, we may see some very different things. And this is a problem we face as well. So if we get this one, we might say this is an Elvis Presley tumor, but we've completely missed the more aggressive Colonel Tom Parker part of the tumor. And if we get this, we'll probably say, I don't know what that is. If it's a frozen section, we probably ask for more tissue. But with biomarkers, perhaps we can determine what this is and how it's going to behave. So this is kind of the way I've often introduced the problem. I'm going to show you a couple of friends of mine, their version, very quickly, and then we'll move on. But this is my friend Peter Vesseling from the Netherlands likes to do it this way. Everybody knows it's a bird, it's a plane, it's Superman. He converts that into 3 neuropathologists. It's an astro, it's an oligo, it's a mixed glioma. It's a grade 2, it's a grade 3, it's a grade 4. And then, of course, the neuro-oncologist and neurosurgeon all conclude it's a big mess. Of course, there is some truth to that as well, though I think this is maybe a little overly harsh. So, nevertheless, these are some common responses nowadays I get from neuro-oncologists, and maybe think about this and think why maybe some of this is okay and some of this is not so okay. But often they'll tell me, you know, I really don't care if it's an astro or an oligo. Just tell me if there's one p19q codylation or if there's IDH mutation. I don't want to know if it's a glioblastoma. I want to know which category, proneural, neural, mesenchymal, or classical. Same thing with medulloblastoma. I want to know, is it Wnt, sonic hedgehog, group 3 or group 4? And of course, the biggest thing I hear all the time from people is, when can we discard this ancient tool called a microscope and just go to a purely molecular scheme? So hopefully by the end of the talk, you will agree with me that that's maybe not the best approach. Okay. Lastly, my friend David Lewis, he likes to introduce the problem this way. Basically, two neuropathologists looking at a cloud. One says, that one looks like a glioblastoma, and the other one says, yeah, but it has an IDH mutation. And so again, we'll learn why that's important. Okay, so just to kind of let you know, we actually were putting together, David and Peter and I have been discussing over the last year and a half, all those developments that have impacted on our field, and it's kind of, we're a decade behind the hematopathologists. They've been doing this for a long time, but it's probably time for us also to start integrating some of the molecular data into our classification and grading. And of course, you're very fortunate here at Johns Hopkins. You've got some of the world's best neuropathologists. And so at this meeting, for example, Peter Berger is on the program committee, and Charles Eberhardt will also be participating in this meeting. It's going to be in Amsterdam in a couple of weeks. Okay, so our goal at this meeting is going to try to balance our desires and needs. Right, so we want to incorporate the latest molecular data and use the most accurate cutting-edge techniques, but we don't want to destroy everything that's been built up for many, many years, including standard clinical diagnosis and patient management, the availability and cost of these techniques, and so on, and very importantly, preserve the kind of continuity in clinical trials and scientific endeavors in terms of our terminology. Okay, so I always show this slide, one of my last intro slides, and that is that we have lots of fascinating new tools for molecular biology nowadays, and the first temptation is to use a $2,000 tool that takes 2 weeks and say, aha, it's a glioblastoma. That's not really moving anything forward, because we can all do that with a cheap H&E within a few seconds. So we really have to, it has to tell us more than what we already knew with the microscope. So, why should we not throw out the microscope? I think it's really important not to throw the baby out with the bathwater, right? And this is a term that comes from an old German publication, Appeal to Fools. And we hope we're not going to be fools. So in my opinion, the baby in this case is about a century worth of clinical pathologic experience, some tight correlations with outcome, and really it's very hard to beat the cost efficiency of light microscopy. The bathwater that we do want to throw out, of course, is the subjectivity that we have, diagnostic pitfalls, some of those mimics, and in essence, the fact that we're not sufficiently reproducible from one pathologist to another. Okay, so now we're going to talk about individual biomarkers and cover quite a few of them. Some of the ones that are already in common practice I'll go through very fast, and then some of the newer ones I'll go in a little more detail. But what everyone should do whenever evaluating any biomarker, especially if you're running a lab for a clinical lab, is to decide, well, what kind of biomarker is it? Is it diagnostic, prognostic, or predictive? And nowadays we also have some that really are none of these, but help elucidate our understanding of the biology. These could, in the future, become predictive markers if they get targeted, for example, with drugs and things like that. Of course, there's practicality issues at the lab. Now we touched on a little bit, and we all have to consider cost and ease of implementation. different types of techniques, some of which are more readily available than others, are easier to perform, and what is reimbursed by insurance companies, what is not. And this, of course, varies greatly around the globe. Okay, so this actually is a cartoon from lung cancer, but it serves the same point. The other thing I think we need to kind of get at is when we find mutations, are they driver mutations that basically the tumor is dependent on, or are they passenger mutations which are really just along for the ride? And I like this part because I think it's very true for neuro-oncology. So when I was a resident, there was a very nihilistic approach to gliomas, and everyone said, oh, they're all bad, why do you even bother subclassifying them, all the patients died, it's just a bad disease, and everybody gets treated the same way. So, but there's tremendous variability among this cohort. Today I would say, well, maybe we have a group that is oligodendrogliomas with 1p and 19q codeletion. That's much more similar in biology, but there's still variability from one patient to the other. It's just less than this variability. Maybe we have a glioblastoma with EGFR amplification and an astrocytoma with p53 mutation and ATRX mutation. And the hope is that tomorrow, at some point, we'll get down to the individual patient level and we'll know exactly what is the optimal therapy for each individual patient. And we're nowhere near that quite yet. So very briefly, the story about 1p19q. This was Greg Cairncross in the late 80s, early 90s. Reported that a group of high-grade oligodendrogliomas had a very dramatic response to PCV chemotherapy, which is procarbazine, CCNU, and vincristine. And compared to glioblastomas, which are much more common, this is really a dramatic. This is before and after chemotherapy. And that was, of course, very interesting, but it got even more interesting when people realized that it was specifically those tumors with codeletion of 1p and 19q arms that had the better prognosis and were more likely to respond to therapy. So really in the late 90s, we had our first biomarker, and this is the one we have the most experience with, that is testing for loss of the short arm of chromosome 1 and the long arm of chromosome 19. The most common way people do it is using FISH, but almost as common is PCR-based techniques with loss of heterozygosity. Occasionally people will use CGH or array CGH. And so basically we should ask ourselves, what kind of biomarker is this? This is kind of unique in that it's all three. So it is a diagnostic marker because it's mainly seen in pure oligodendrogliomas and helps us when the differential is with other tumor types. It is a prognostic marker. Those patients do much better than the ones that don't have the codeletions. And we argued about whether it's a predictive marker for a long time, and only recently were the original clinical trials did they gather enough clinical data to answer that question, and the answer is yes. So patients with oligodendrogliomas that have 1p and 19q codeletion that get chemotherapy and radiation, the average survival now is 15 years, so it's really quite a dramatically favorable subtype. We and others studied different subtypes over the years, and like many things, found that kids are not just small adults. So what's true in adults often is not true in the pediatric cases. Only rarely did they have this genetic pattern, and it was typically teenagers. So the way I think of it is that sometimes teenagers have adult-type tumors, just like sometimes young adults have pediatric-type tumors. Okay. Now, a key discovery made here at Hopkins in 2006 by Connie Griffin, and then later, shortly, almost simultaneously, Bob Jenkins at Mayo Clinic found the same thing, is that the codeletion of these two arms results from a non-balanced translocation between chromosomes 1 and 19. And what causes that, I'll tell you in a little while. We've gotten a little bit of a clue into I can tell you when I was a fellow in around 95, Bob Jenkins, I worked with him, he said, you need to get into my lab quickly because in the next 3 months we're going to have the 19q gene. Now I can tell you the 19q gene was not found in the next 3 months. It was not until 2011. I'm still not sure this is the only 19q gene, but this seems to be the most common gene that is mutated in the other copy of the, that's in the arm that is not lost. So this frequently accompanies the 19q loss. To a much lesser extent, this gene is also mutated on 1p. So I'm still not sure we have all the genes for this discovered. Still now it's easier though to detect the 1p and 19q codeletion than to look into CIC or FUBP1. So that's still what most people are doing. A couple of other markers that have been around a long time that we mainly look for by FISH. One is EGFR gene amplification, and that is seen almost exclusively in glioblastomas. And chromosome 10 losses is not quite as specific, but also mainly seen in glioblastomas. So these are markers we mainly use as diagnostic markers. They're prognostic only if you look at them on univariate analysis. On multivariate analysis, they usually are not significant because they're so tightly linked with the diagnosis of glioblastoma. Are they predictive markers? Probably not in most of the studies that have been done so far, although these are still used as criteria for some of the clinical trials that people look at. So mainly we do this by FISH. A more interesting one that oncologists got very excited about several years ago is the gene MGMT, or methylguanine methyltransferase. It's a DNA repair enzyme. And it's mainly inactivated by methylation in CpG islands. And in fact, because this is a DNA repair enzyme that mainly repairs the type of damage that is done by alkylating chemotherapy agents, the ones we use to treat gliomas, it was predicted that if this gene is inactivated, those tumors would be more susceptible to chemotherapy and would have a better prognosis. And this turns out to be true, though it's probably not all that simple, but this turns out to be a good marker. It is not by any means a diagnostic marker because we see it in many glioma subtypes and many non-glial tumors as well. It is definitely a prognostic marker and maybe a predictive marker. And the reason I say maybe is even though it predicts a greater chance of response to temozolomide therapy, which is the standard of care we use now, if you ask oncologists, what are you going to do for the patient who is negative for methylation, their answer is, I'm going to give them temozolomide. And the reason is they just simply don't have that many other options that are good options, and still a subset of those negative patients respond. So in the future, it may become more of a predictive marker than it's being used right now. It's really mainly used as a prognostic marker. By mainly PCR, methylation-specific PCR, there are other techniques. It was hoped early on that we could convert this into an immunohistochemical assay, but it actually doesn't correlate very well with outcome and with response to therapy. Probably because they're hard to interpret. There's always a lot of normal cells mixed in the background. But in any case, the standard now is PCR. Okay. This is probably, I'd say, the most important, in my opinion, the most important discovery in the last decade for gliomas. And kudos to Johns Hopkins on this one. Johns Hopkins and Duke and a few other places. But it was discovered through whole genome sequencing of a number of glioblastomas that not only did they have some of the alterations we already knew about, but at least one that no one had ever reported before. And that is a mutation in isocitrate dehydrogenase, most commonly type 1, although in rare cases type 2. So This was found in maybe 10% of the cases, and those patients had a significantly better survival. And they tended to be younger patients, and they tended to be ones with secondary types of glioblastomas. In other words, those that started as lower grade astrocytomas and later became glioblastomas. So that was interesting, but then people looked at grade 2 and grade 3 gliomas and found that in fact this is the most common mutation in all of the diffuse gliomas. It's probably the earliest one in one of the major pathways of gliomas. So 70 to 80% of grade 2 and grade 3 gliomas and secondary types of GBMs have a point mutation in IDH1 and less likely IDH2. So it's really became very exciting. And this moved very quickly from that time. A group from Heidelberg, basically because one point mutation accounts for about 90% of all the mutations that we see, the group from Heidelberg created a monoclonal antibody against this mutant form of IDH1. And so now we've converted a molecular assay into immunohistochemistry. And we use this, I can tell you, we use this every day. It's incredibly useful. First of all, I will tell you that, like the story with 1p19q, when you look at kids, the answer is they don't have it commonly. So again, the pediatric tumors have different pathways than, to get to the same tumor types than their adult counterparts. But here's the antibody. In a case where we were struggling, it was only minimally hypercellular, and we were struggling, is this, maybe there's a rare atypical cell, is this a glioma or not? IDH1 was positive and highlighted many more tumor cells than what we would have guessed, and that's diagnostic. This is only seen in diffuse gliomas. Nothing reactive or non-neoplastic is going to stain. So it's a very useful diagnostic marker. Also a very useful prognostic marker because this is a pathway that generally has a better prognosis. So this is in an oligodendroglioma with 1p19q. So it's interesting, this is seen in both astrocytic tumors and oligodendroglial tumors with 1p19q codeletion, without 1p19q codeletion. So again, thought to be one of the earliest alterations that we're seeing. So it is diagnostic, it's prognostic. At this point, it's not predictive because there's no specific targeted therapy, although people are working on that, and maybe in the future they'll have something. Now this I stole from David Lewis from one of his talks as well, but this is an article from, again, the group in Heidelberg, where they combined histology and IDH mutation status and looked at grade 3 and grade 4 tumors with IDH mutation and with IDH wild type. And the first thing you're probably going to say is, well, okay, these are the grade 3s and these are the grade 4s. In fact, that's not the case. These are the IDH mutant, and these two are the IDH wild type, regardless of whether they're grade 3 or 4. So in fact, a grade 3 astrocytoma with IDH mutation does better than, a GBM with IDH mutation does better than a grade 3 tumor without it. So David has this kind of provocative question in his talk. Should a GBM with IDH mutation be called GBM grade 4 with an IDH mutation? An anaplastic astrocytoma, since it behaves more like a grade 3 tumor, or a glioblastoma grade 3, which is kind of a radical notion, but this is something we'll discuss at the meeting. So these are I would say, these are the markers that now have been around for a while, and we use, almost all of us use them routinely. And kind of some of the early conclusions before we go on are, whole arm 1p19q codeletion is relatively specific to a genetically favorable type of oligodendroglioma in adults. Pediatric cases are different. It's an early alteration, but IDH mutation seems to be earlier. These IDH mutations are seen in all three subtypes, astro, oligo, and mixed, as well as secondary glioblastomas. And it identifies a more favorable kind of pathway along the diffuse glioma category. Okay. EGFR amplification 10q losses, they've been reported in some cases as being common in oligodendrogliomas, but then they behave like GBMs. So my argument would be really we should call these GBMs, and it's one particular type, the small cell type of GBM, that Peter Berger was very involved in identifying, and we collaborated on the study. Those frequently have EGFR amplifications and 10q losses. The MG methylation studies, we're all doing them, but I can tell you there's lots of problems with them. There's a lot of technical difficulty sometimes with doing this assay. It's still not clear what's the best technique. Pyrosequencing may be better than methylation-specific PCR, or MLPA might be better. There's almost 100 CpG islands in this gene. Which ones should we be testing? Are some of them more important than others? So there's still a lot of unanswered questions. Sometimes one area of the tumor is methylated, another area is not methylated. It's methylated in the primary tumor. When it comes back, it's not methylated. So there's still a lot of unanswered questions, I think, with MGMT. But again, I think the combination of both light microscopy and molecular is more accurate than either one by themselves at this point. Now, just to give you one example of the Elvis Presley impersonator in terms of tumors, these are two tumors that look very much alike, as I kind of alluded to. Anaplastic oligodendroglioma, small cell GBM. This has its own unique molecular profile. Average survival now 15 years. Still a question about whether you can give chemo by itself up front. This GBM, like other GBMs, average survival is only about 1 year, and commonly treated with combination radiation and chemotherapy, and of course very different clinical trials than the oligodendroglioma trials. So it's a very important distinction. Okay, so here are some new biomarkers. All of these have come out in the last 5 years. Some of them are being used clinically, most of them are not, but they probably will be in the near future if they're not already. And I'll tell you a little bit about each of these. Okay. So there is something called the CpG island methylator phenotype, or GSIMP, for glioma CpG island methylator phenotype. And not only MGMT, but dozens of genes all seem to be hypermethylated at the same time. And this is a nice study by Ken Aldapi from MD Anderson. Now he's moving to Toronto. And you can see this is clearly a prognostic marker. So you can detect this with global methylomic types of techniques, which is not readily available to everybody. But nevertheless, you can see a very marked association with prognosis, even when you correct for grade. The thing is that this is very highly linked with IDH mutation and with other favorable prognostic indicators, so it's a little unclear whether you should add this to the plate or not. There's a reason that these are now highly linked, and we've identified this. This is a review by Sridharan Vanetti. We now know that one of the downstream effects of IDH mutation, this is an enzyme involved in the Krebs cycle. It was kind of a mystery, why should that be involved in gliomas? But one of the metabolites that accumulates can be as much as 100 times the normal level, is 2-hydroxyglutarate. And that seems to have secondary effects on chromatin remodeling and transcriptional regulation. And so this is probably where the effect is of the IDH mutation. And one of the downstream effects is this hypermethylation phenotype. So in fact, IDH mutation causes GSIMP. And virtually all cases with IDH mutation also have GSIMP, although the reverse is not always true. Another recent discovery was looking at telomerase mechanisms. So we've known for many years that the H-TERT, the telomerase reverse transcription enzyme, is often overexpressed in high-grade gliomas. But we didn't know what the mechanism was. And it was recently now identified there's 2 common mutations. And instead of being in the coding region, these mutations are in the CPG islands, in the promoter region. And so these are the 2 common mutations you have in TERT. So this is one of the main mechanisms that gliomas and many tumors and cancers all over the body use to escape senescence, cellular senescence. But it's not a random kind of event. So oddly enough, in the gliomas, the 2 types that have this most often are primary glioblastomas, the worst of the tumors that we see, and oligodendrogliomas with 1p19q codeletion, the best. So it's kind of ironic that the worst glioma and the best glioma are the ones that mainly use this mechanism. There's an alternate mechanism for escaping senescence called alternative lengthening of telomeres, or ALT. This has been studied greatly, for example, in pancreatic neuroendocrine tumors. It's very common in that tumor type. But this also leads to, this mainly comes from mutations in one of 2 genes, and in gliomas it's almost always this one, the ATRX gene. In pancreatic tumors it's also DAX. But this is again a gene that has effects on chromatin remodeling, telomere structure, and transcriptional regulation, so lots of downstream effects. It's becoming kind of a common theme in brain tumors. So you get these huge telomeres with this mechanism, and we can detect that with telomere probes with fish. You get these very large, ultra bright signals. So this is one way to detect this alternate mechanism. This isn't normal, this is negative. These are just normal telomeres. But like in the case with IDH1, we now have a surrogate with immunohistochemistry. So we can look for ATRX is normally expressed in all nuclei, but the vast majority of mutant ATRX are going to have loss of expression. So we can detect most of these cases simply by using immunohistochemistry. So endothelial cells, inflammatory cells, neurons, they're all positive. The tumor cells are going to be negative. We've just recently started using this routinely on the clinical service. And I'll show you why that is in a second. So we and many others found that this is a reliable way of, there's a highly positive association between loss of expression by immunohistochemistry and the ALT phenotype. It's commonly seen in mainly astrocytic tumors. So oligodendrogliomas with 1p and 19q codeletion do not use this. They use the HTERT mechanism. Astrocytomas frequently use this. So to some extent, this is another way to kind of help you with the astro versus oligo. So it's another useful diagnostic technique. We found in our study, both in pediatric and adult cases, also that the ones that have high-grade astrocytomas with ATRX mutation and ALT phenotype often have PDGFR amplification as well. There seems to be some link there. So if we're looking at receptor tyrosine kinase alterations, the most common, as I mentioned, was EGFR in primary GBMs. The second most common is PDGFR alpha amplifications, which here it says 13% based on TCGA data. By fish, it's about twice that, and that's often because there's only scattered cells that are amplified, or it's a lower level amplification. So fish is more sensitive than other techniques for picking this up. This is mainly in the secondary GBMs, and is sometimes seen alongside with IDH mutation. And we found specifically in those cases, if you had IDH mutation, here's that favorable prognosis, but if the IDH mutation was associated with PDGFR amplification, then you lose the favorable prognosis. So this is a relatively small subset, but probably one of the progression-associated alterations in this subset. Okay, so now people are putting together these charts of the common biomarkers. And what you see, primary glioblastomas mainly have HTERT mutations. They mainly have the EGFR amplifications. And oligodendrogliomas also have H-TERT mutations, but they're coupled with 1p19q coded lesions here in yellow. In contrast, the astrocytic tumors mainly have ATRX mutation, p53 mutation, and IDH mutation, as you see here. So we can kind of help classify our tumors using a combination of these markers. So for example, here's a low-grade astrocytic tumor, IDH positive, strong p53 positivity. This is by no means proof that there's p53 mutation, but it's at least suggested, and loss of ATRX expression. So now we're starting to get vocalgrams, like the hematopathologists have done many years ago. And it's also, I think we're starting to understand how these gliomas develop a little better. So the thought nowadays is that the earliest alteration in this pathway is IDH mutation, which causes G-SYNP. If you add on top of that a translocation between 1 and 19 with loss of 1p19q, sometimes mutations of Syk and FUCB1, that pushes you towards the oligodendroglial lineage. Whereas if you have p53 and ATRX, pushes you along the astrocytic lineage, and then a number of other alterations are involved in progression to secondary GBM. The most common pathway is the primary GBM. That has EGFR amplification commonly, loss of chromosome 10, gain of 7, and other alterations, p16 and things like that, and TERT mutations common in all of these. Now, earlier, this was in 2010, like many of these kind of genomic TCGA-based projects, I had our oncologists literally a week later asking us when can we start, stratifying our GBMs this way. So by expression profiling and SNP array and a variety of other techniques, this group thought that there's probably 4 molecular subsets of glioblastoma. The problem is they only have this one group, the proneural, has a slightly better prognosis than the others, and the others don't seem to have, at least at this point, any clinical significance. If you ask an oncologist, do you have a neural-specific therapy or a mesenchymal-specific therapy or a classical? No, they don't. So, why is this so critical? Also, I never did like the fact that all of these different alterations were in the proneural. IDH is good, but PDGFR usually is more aggressive. So I actually like a kind of an updated version from this group, again from Heidelberg, where they also included pediatric glioblastomas, and they also looked at methylome testing, and they decided there's 6 subsets of glioblastoma. The IDH1 is mainly the secondary type. It's mainly in young adults, mainly hemispheric tumors, much better prognosis than the others. This one is mainly in kids. It's mainly central tumors, especially pontine gliomas and thalamic gliomas. And it's a K27M mutation in the histone 3 gene. And this has a terrible prognosis. This is the worst of all. Virtually limited to kids and young adults. We now just recently developed an antibody for this mutant form, so this may be converted to an antibody as well. And then there's in the same gene another mutation that seems to have an intermediate prognosis, slightly older age of onset. And then they separated out the PDGFR amplification group from the EGFR, and this is kind of everything else that's left over. So there are some surrogate immunohistochemical markers for some of these, for some there aren't. And that's kind of where we are with the gliomas now. So just very briefly, I'll tell you the same story that I told you with gliomas is going on with medulloblastomas and a variety of embryonal tumors. And nowadays with genomic techniques, it's now believed that there are 4 molecular subtypes of medulloblastoma, a couple of which we can detect immunohistochemically, a couple we can't. The Wnt pathway, so the Wnt signaling pathway activated type is the best prognosis by far. And these are mainly in kids, not infants and not adults, but mainly in kids. And they have beta-catenin mutations, and it's argued that these patients we need to recognize because they may actually get away with less aggressive chemotherapy that's less damaging to a developing nervous system than what we use now. The sonic hedgehog is another major pathway, and these are seen in two age groups mainly in infants below the age of 3 and mainly in young adults. These often can be picked up immunohistochemically, I'll show you in a minute, with GAB1. They sometimes have patched mutations, and in the infants seem to have a really excellent prognosis, and in the adults it's a standard prognosis. This one is the worst. It's mainly isochromosome 17q and MYC amplification, group 3. They need more aggressive therapy, and this one is kind of an intermediate group again, also with isochromosome 17q. These two groups are often hard to separate with the biomarkers that we have now. So I was involved peripherally with a study with David Ellison and Richard Gilbertson looking at can we use some markers to try to stratify these groups. And the best we could do is sonic hedgehog, Wnt, and group 3 and 4 together, basically. So here's beta-catenin. Believe it or not, this one is negative. So beta-catenin is normally expressed in the cytoplasm. It's only when there's nuclear positivity that implies that this is the Wnt pathway group. GAB1 is mainly seen in nodular desmoplastic medulloblastomas in between the nodules, as you can see here, and at higher magnification. But sometimes they're in classical subtypes as well, and here you can see this tumor crawling along the subarachnoid space and back down along Burkhoff-Robin spaces. For group 3 and 4, we can kind of get a sense of that. They often have isochromosome 17q, which we can pick up by FISH. And the c-MYC amplifications we can pick up by FISH as well, but that's only a minor subset of the group 3 tumors, so we can only really pick up a minor component of that. But there's a lot of work going on in that group as well. Another embryonal type of tumor that's seen almost exclusively in infants is atypical teratoid rhabdoid tumor. We've known for many years now. These have a horrible prognosis. Many of the seminal papers were involved Peter Berger in describing these cases. They're often misdiagnosed as Glioblastoma as peanut, but you can see what a horrible prognosis they have. So they need much more aggressive therapy, and many of them die even with more aggressive therapy, but it's completely different therapies in medulloblastomas. And they also have a genetic signature with inactivation of the INI1 gene on chromosome 22. We've known that for a long time. We used to do FISH, and we could pick up about 70% of the cases that had chromosome 22 deletions. But now, again, use the same theme. We now have a great immunohistochemical marker. So INI1 is, again, involved in that same SWI, SNF chromatin remodeling pathway that ATRX is involved in, and it's normally expressed in all nuclei. So we're looking for loss of expression in tumor and retained expression in endothelial cells and inflammatory cells. So now we pick up, I'd say, at least 98% of the cases with just this one immunostain. There are rare cases that involve other members of the chromatin remodeling pathway. So very briefly, these are a few other markers that may make it on the scene in coming years, or already are to some extent. In pilocytic astrocytomas, the grade 1 gliomas, common ones, they often have a fusion and duplication of the BRAF gene involved with this other gene. We can pick that up by FISH, although this is a somewhat difficult assay, or by PCR. It may be that these are more responsive to MEK inhibitors, so it may be a predictive marker in the future. BRAF V600E, our pediatric oncologists ask us to do this all the time, and sometimes with good reason, sometimes without, but PXAs often have these gangliogliomas. A smaller percent of other gliomas will have that, and some of these patients, at least initially, seem to respond to BRAF inhibitors. So here's the FISH showing BRAF and KIAA. We're looking for this fusion, this yellow fusion, plus a gain of the red and the green signals. Okay, and this was the article, one of the main articles showing how common this is. The same alteration seen in melanomas, thyroid cancers, and colon cancers. So this is by no means a diagnostic marker. You can't say something with BRAF V600E has to be a PXA. But it is potentially a predictive marker. Okay, so we mainly do this by sequencing, but it won't surprise you to find that now there is a monoclonal antibody, VE1, to the mutant form of BRAF. I don't think this one works nearly as well as IDH1, but it's still a useful technique, especially in a small biopsy where it's hard to do PCR testing. So just to give you a sense, when I came in 2010 to UCSF in neuropathology, we had less than 100 molecular assays, and we're up now at almost 2,000 just within a few years. So this is growing exponentially, like it is with, I think, just about anything else. So we're going to be seeing a lot more of this. It's going to make its way into classification and grading. These are some of the things we've converted to immunohistochemical stains. And again, we just have to remember this balance. So, with that, I'm going to, you sat through a lot of heavy detail, so now I'm going to give you something a little lighter. This is something I've done for many years with our medical students, and that is help them memorize some of the facts from the lecture I just gave with a neuropathology song. And a few years ago, I put these together on a CD, and they're available on iTunes and Amazon and just about anywhere you want to go if you're interested, but it's a fun way to learn. And a good friend of mine helped me convert what was just guitar and voice into full arrangements. And so a few years ago, I decided I needed a song for oligodendroglioma with the 1p19q codeletion. That's what you're going to hear today. And I struggled. Some of these I used original music, many of them I used publicly available music. And so at one point, my son's teacher, who's Catholic, got married, and she asked me to sing Ave Maria at her wedding. And so after that, my wife said, you know, for a Jew, you sing that pretty well. Why don't you use that for oligodendroglioma? And it turned out to be the perfect choice. So I will now sing for you the oligodendroglioma song. If you feel like singing along, by all means.
prognosis with pediatric oligos since they don't have the IDH mutations?
Yeah, good question. So the low-grade oligodendrogliomas in pediatric cases seem to have an excellent prognosis. It's not clear what is driving those cases. The anaplastic ones, the high-grade ones, don't seem to do quite as well, but they're fairly uncommon. So it's unclear. We always know less about the pediatric cases, it seems. All right, thank you for your attention.